Hi, so you have a small baby and who's been spitting up a lot recently, and you're looking for some answers and wondering what's going on. So today I wanted to talk about one of those reasons for spit ups. It's called reflux disease or pediatric gastroesophageal reflux or GER or GERD. So I am Dr. B, a board certified pediatrician and a pediatric critical care doctor with a long experience in taking care of small babies and sick children. So what is reflux? So what happens with reflux is, so you have your feeding tube or the esophagus that goes into the stomach, and at the bottom of that esophagus with a junction between the feeding tube and the stomach, there is a sphincter. Now in babies under the age of 1, that sphincter is a little bit immature, and so it's kind of physiologic, right? So it'll mature with time. However, due to this immaturity of that sphincter, time to time that sphincter just relaxes, and that causes a backflow of the stomach contents up into the esophagus and out the mouth. It comes as spit up. So that is the basic reason why babies spit up with reflux. So it's an immaturity of that lower esophageal sphincter, and that does get better with time. So that's why it's a physiologic condition in most of the cases. Okay, so how do babies with this reflux present? So the most common obviously would be, spit ups with feeding, not really projectile vomiting, and I talk about the other cause of vomiting in babies in my other video on pyloric stenosis. However, in this instance, the babies are just spitting up or dribbling from their mouth, and it's happening a lot after the feeds. And some of the other uncommon ways that babies with reflux can present are things like just being very fussy, crying, irritability. Sometimes more common in premature babies, they can also have what we call apneas, where they do they hold their breath or they stop breathing. So they can have apneas, bradycardia, where their heart rate drops as a consequence. Sometimes in the hospital, I see a lot of these babies coming in with what we used to call ALTs, or acute life-threatening event, or now they are called bruits, where a lot of these cases are actually related to reflux, where it's typical stories that they are feeding and then they just sort of choked and stop, breathing, their heart rate drops, they become blue, and then they come to. So ALT is one of them. Sometimes these babies can present with frequent wheezing because they are probably aspirating it into their lungs. They can have vomiting, and then a lot of these babies also can sometimes not gain weight. They have failure to thrive. Those are some of the common ways that reflux presents. Another way that reflux can present is just by chronic cough. So you may not notice anything else, but just chronic cough, and then they have sore throat, hoarseness of voice, and this is all related to the aspiration of the stomach contents which are coming back up. So those are some of the ways. And then there is one particular thing called Sandifer syndrome, which can happen in babies with reflux. Not very common, I've not seen it that often. It's in extreme cases, what happens is as the baby eats, they are in extreme discomfort as that acid and everything else is coming back up their food pipe. So they arch their backs. So they, you'll notice that their back is kind of like arched. So their neck is extended, their back is arched, and their baby kind of goes into this position after feed. So this is called Sandifer syndrome. So that would be a very classic way, and the diagnosis is made of reflux if that baby presents like that. So how do we make the diagnosis? So your pediatrician would typically make this as a clinical diagnosis based on the presenting features. However, in some cases, we may need to do an upper GI, or even an endoscopy with biopsy can be indicated if reflux is being suspected. Some of the other things are, we used to do more like the milk scan, which is more to test for aspiration, and then pH probe study. However, in majority of the cases of simple reflux, just a clinical diagnosis is sufficient. So now that we have made the diagnosis that this is reflux, how do we treat it? So the recommendation from the American Academy of Pediatrics is, if the baby is doing well, so there is no signs of weight loss, the baby's thriving, there is no failure to thrive, and there's not severe symptoms, then it's gastroesophageal reflux or GER. Those babies do not need to go on medicine. Okay, so your pediatrician would recommend conservative measures. So what are conservative measures? So things like reflux precautions. So after you feed the baby, do not lay the baby flat. Make the baby maybe sit up a little, propped up, And if they're older than 6 months, you can try prone positioning, obviously supervised, because you know the risk of SIDS. So, but can try that, and you know, good burping. And then the other thing would be maybe thickening the feeds with cereal, so that helps to keep that food down. So those are some of the conservative measures, because physiologic reflux, like I talked about before, because that sphincter is immature. However, by the time they are 1 year old, that sphincter kind of matures, and this reflux in babies, that's better, so we don't need to go on medication. Now there is a group on whom medicine is indicated, and who is that group? So they would be when we have what we call GERD, or gastroesophageal reflux disease, and those are babies where it is severe enough that is affecting their growth. So if they are failure to thrive, not gaining weight, if they have Sandifer syndrome, if they have chronic apneas and Brady's, they're wheezing, chronic cough, so it's affecting them in other ways, then they would need to go on medication. And what are the medicines? So it's typically the acid suppressing medicines. So it's H2 blockers. So things like Zantac, Pepcid, that's one class. And then if it's a little more is required, a higher class is your proton pump inhibitors, or your PPIs. And examples of those are your lansoprazole, omeprazole, esomeprazole. Those can also be done. So majority of the babies that we see in the outpatient setting is either managed by conservative measures, and then the next step would be by medications. Once in a great while, in babies who have other issues, more like complex medical problems, they may need surgeries, things like a Nissen fundoplication and a G-tube. But those are not, we are not talking about just, otherwise healthy babies presenting with reflux. So that, in a nutshell, is pediatric gastroesophageal reflux and reflux disease. I hope that helps explain. And this is one in my series on vomiting and spit ups in babies. You can watch my other video on pyloric stenosis, which is also one cause for vomiting in children. However, it's a more rare disease. So please subscribe to my channel, and that way you can be notified of whenever I post a new video. Thank you.